in the wider emergency medical system, if I can call it that, I sit down in the bottom left-hand corner. I sit in my regional specialist hospital, surrounded by a great deal of very, very highly qualified and skilled people, and lots of equipment and lots of resources compared to many of my colleagues in the 17 other hospitals in the area called the East of England. I focus on emergency presentations, and I don't define myself by the walls of my department. This idea that we just sit in our ivory tower and wait for patients to come to us is no longer really tenable. We reach out across our region to find patients who need our specialists' care. The WHO tell us that there are roughly 1.3 million deaths a year from road traffic-related injury worldwide, with a significantly larger number of people with permanently disabling injuries. And that problem worldwide is getting worse. By 2030, it's expected that road traffic-related injury will be the 5th commonest cause of death in the world. So worldwide, this is a huge public health problem, like any other disease. In our region, we've been able to quantify the burden of disease using a project which was partly funded by the Strategic Health Authority and indeed by the charity MAGPAS. And it was a project to try and quantify what we mean in terms of this burden of disease for our population. And what MAGPAS did is collect 5 years' worth of data in the geographical county of Cambridgeshire on everyone who was injured, and explored the who, what, why, where, and when, and was able to determine, on this chart here, a kind of spectrum like that pyramid of injury, and that tells us that on the far right there, that major trauma, a so-called injury severity or greater than 15, would affect 12 per 100,000 population per year. So we want to stop that. We want to stop the injury event from occurring in the first place. But sometimes we can't. And for 600 to 800 people a year in our region, we need to have a system in place for managing their needs once they have had their road traffic collision or their fall from height or their industrial accident or their sports-related accident, fall from horse, and so on. So I'm going to focus a little bit more about what we've done to develop and improve our systems for post-event injury management in the East of England. This is our system back then. The East of England, the 6 counties, 20,000 square kilometers, 5.8 million people with a population density that's very variable, and 18 essentially independent acute hospitals. A whole range of other providers, a single ambulance service, 6 pre-hospital charities supporting the ambulance service, and a whole bunch of NHS and non-NHS specialist and community-based rehabilitation providers. Well, let's say, in that graph I showed you, it was 12 per 100,000, but on the next level up, it was 22 per 100,000. So let's say there are 1,200 patients a year, double what I said before, who are major trauma patients in that population. So that's 18 hospitals, meaning about 70 patients per hospital per year, meaning 1 to 2 of these patients per hospital per week. And if I was doing a 1 in 4 rota, I might see 1 to 2 a month. If it was a child, I'd see 1 or 2 a year, because this condition is rarer in children. So I'm not going to get comfortable and confident and experienced in the management of this disease, because I'm not seeing it. And 12 per 100 population per year is the same sort of incidence as testicular cancer, new diagnoses HIV, tuberculosis, other rare conditions, childhood leukemias, which we wouldn't expect to be managed spread out across 18 different hospitals in our population. We'd expect these conditions to be managed in specialist centers. We need to provide, increase or improve the tempo of decision-making, the tempo of care, get more senior people involved, get further resources targeted at these patients, and if necessary, move the patients to where the resources are, and change the way we think about this disease. It's not an accident that we can't predict. It's a life-threatening emergency that we can predict, we know it's going to happen, and we know what to do about it. So our East of England trauma network looks like this. I'll talk through that. So we have designated 12 of the 18 hospitals as trauma units. 2 of them are not trauma receiving hospitals anymore. That's because they don't have the facilities necessary to care for these patients. 3 of our 18 hospitals feed into the northeast and northwest London trauma networks because they're geographically closer. So Watford, Southend, Basildon, it was more appropriate for them to be linked to the London trauma system. The remainder linked to CUH in terms of policies and procedures and shared care models, if you like, around how these patients should be managed, when they should be moved, both to us for specialist care and recovered from us for ongoing care. Now, keeping track of all this and understanding this disease has also been a real challenge. We want to continually measure what we're doing. We want to show that we're doing the right thing. And one of the things we've tried to do is implement a sort of cloud-based or web-based information management system to let everybody communicate across this big geography in real time to case manage the patients. And we've worked with some commercial providers to provide cloud-based, web-accessible, NHS information governance compliant case relationship management software that has been nominated for a Patient Safety Award nationally this year because it's starting to change the way we communicate across hospitals and between the ambulance service and the hospitals about these patients. So a complex system, a new system that went live only in August last year. We're less than 1 year in. Although we formally became a major trauma center last April, we didn't roll out across the whole geography until August. It takes 3 to 5 years for a major trauma center and system to bed down. So we've got a long way to go and a lot to do. I won't go through in detail, but we've got quite developed pathways now about what happens to patients when they come in to the emergency department, where they go, the critical care management of these patients, the onward management of these patients in our new rapid access acute rehabilitation facility, and so on. We've seen about 360 patients so far this year. We're expecting to see about 600 if everything goes right. We're on track pretty much in terms of our volume of expected activity. And you'll be pleased to hear that our outcomes, in terms of the latest data we have, show what are referred to as 3 unexpected survivors, 3.3 additional survivors out of every 100 patients. We care about major trauma in this hospital and in this region. Our national peer review visit in March rated us as one of the best and most developed regional systems in the United Kingdom, and I hope that we'll continue to grow from this point. Thank you very much.